Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today we're going to go over en route casualty care. And today I'm with Paul, which needs no introduction, but our special guest is Nikki. If you could just introduce yourself a little bit, please.
Hi, so I joined the Navy way back in 1995. Started out as a corpsman and then went search and rescue corpsman for about 7 years, and then did a commissioning program to become a nurse, went to school for my BSN, and am now a nurse for the Navy. I've served with the Marines on the ship in various different operational environments, and I've deployed in those positions. So I have a little bit of experience. My whole career has kind of been around flying. When I was a search and rescue corpsman, we were on helicopters, and then as a nurse, when I was deployed, I was always around helicopters. And my last duty station, which was with the Marines, I created a en route care training for my corpsmen and for my nurses. So, just
outstanding. If you don't mind me asking, why did you feel the need to start a course like this?
I started it because when I was in Afghanistan myself, I found myself doing en route care en route care missions without really the proper training. So I was a pretty junior nurse. Was an ICU nurse, quote unquote, didn't have a lot of experience in a busy, high acuity ICU, but was considered one in the Navy's eyes because I was in an ICU in a medium command. So not a lot of experience. Found myself on the back of a helicopter with very critical patients on vents and blood and drips and, all kinds of different medications that I wasn't completely familiar with. And I decided I did not like being in that position, and I didn't think it was right to have us out there training or doing missions without the training. So I made it my own mission to come back and train anybody who wanted that kind of training. And then my last duty station, my commanding officer was very supportive with it and wanted me to create something for our medical battalion, because we still had deployment taskers and we're still sending people, and that possibility of doing en route care is pretty high. So I wanted to make sure that, I could take all of my experiences and my lessons learned and create something where I can train the nurses and the corpsmen to do that job.
Oh, outstanding. And that's exactly why we have you here on the podcast. So just jumping into it, from your experiences, what problem areas or what are common mistakes that people make when they're preparing a patient for flight?
The common mistakes are the planning. I would say that the pre-flight assessment is huge. So you have to know what kind of patient you have, what you're dealing with. Making sure you get a good handover report from whoever you're taking it from. So whether it's a ground person or if the patient's been in a prolonged field care situation, what those people have done for him. Or if you're going from a role 2 to a role 3, which is more our bread and butter. You got to know what happened to the patient, what's going on with them, what interventions were done, and then you have to do your own assessment and make sure that you're staying ahead of the curve. So you want to not only look at your patient and see that, okay, they're stable right now, but what could possibly go wrong? So if they're vented, what can go wrong in the aircraft? They have breathing issues. How do you stay 2 steps ahead of that? How do you plan for that? And what equipment do I need to bring to take care of them once I'm in the helicopter in a very demanding, stressful environment with no resources and nobody else around me? So that's one of the big things. And then packaging them appropriately for that environment. So, we always talk about that heat loss and the hypothermia. So you got to make sure, once you're in that aircraft and you go up in elevation, it gets colder. So you got to really plan for being able to keep them warm. And then all of your lines have to be in order. You have to know where they are. You have to have easy access to them. Your vent tubing, if they're vented, has to be not hanging out loose and flopping around everywhere when you approach the aircraft, because any little thing, if your IV line comes loose, or if you have an art line that comes loose and you don't realize it, and now they're bleeding out into their apples or whatever, and now you have a hypovolemic situation that you caused and totally preventable. So making sure your lines are in order is one of the higher priorities. And then just planning to be flexible, because for us in the Marine Corps and Navy, we don't have aircraft that are set up for medevac, so we have to be able to, if I thought maybe I was going to position the patient one way on the aircraft, it could change as soon as I get on there, just based on if the crew chief wants me to be somewhere else. So I have to be flexible, be able to, handle my monitors or turn them or do whatever I need to do, so I can still take good care of that patient.
Are there ever times when you have to advocate for your patient against what that crew chief wants?
There could be times, because the crew chief doesn't have medical experience, so they're just thinking, the way they think is, what's easier for the crew right now. So if I have them in the back corner or something, that's going to be easier. If they have to load patients on and off, how is that going to be easier for them? Whereas that might not do well for my patient. So I'll have that conversation with them. And usually, they understand once I explain it to them, but there is always that chance that they're just like, no, just get on the bird. And a lot of times we don't have time to argue about this. So again, I just have to be flexible and figure it out and know that, it might not be the best situation or the best positioning, but I got to overcome that. So.
Right. So, it definitely is a balance between, packaging the patient and gaining access. So you want to keep them covered up. You want all your equipment right there, but you also have to get easy access to the airway, to IV lines, et cetera, et cetera. So is there any principles that you go by, or any techniques that you use to make sure that you will always have access?
Well, one of the nice things, we like to use the apples, which is the brown, it looks like it came from the idea of using a body bag and cutting out the face for it, and then somebody came back and created what is kind of like a body bag or a sleeping bag. But what's nice about it is that it has Velcro all down each side, and you can open the Velcro and then stick your hands in without having to unzip the entire system. So having the access or lining up your lines within like those Velcro pockets where you can, so okay, if I put my hand in this pocket, the IV line should be right there, and being able to feel for that. So that's in our supply system for the medical battalion, and I prefer to use that. If you don't have it and you have to wrap them up in blankets, then you just have to maneuver. You have to know where your lines are, and when you wrap them up, to know that I need to gain access to my IV lines, or be able to feel at least, reach in and feel and make sure it didn't come loose and blood isn't going everywhere or whatever it is. So that's just kind of how I go
so
by it.
So when you set up your patient, your lines aren't coming out the hole where his face is sticking. You put them kind of perpendicular through the Velcro and then close them off.
Yeah, you can. You can just line it, where it's near that Velcro pocket. And then the other thing is, if you don't have that Apple system, you can also use some extra corrugated tubing from your vent that usually comes with an extra piece of plastic. Slice it down the middle, put all the lines into that, and then wrap it up, and then all of your lines are secured in one area instead of all over the place. So, but the biggest thing is to make sure lines aren't hanging loose, or your vent tubing's not out and just hanging, because when you move your patient, so the movement of the patient's always the critical time, because when you're stationary, you have more control over what's going on and where everything is, but the movement, especially in our environment, you might have, for us, some Marines that are standing by, like, hey, can you help me with this patient? They're not medical. They don't really care about what's, the tubing, or they don't even know what all of that is. They're grabbing that patient and trying to get as fast as they can to the helicopter or whatever vehicle you're using. And they may pull things and not realize it, or maybe do it and not tell you. So that's always, that movement, that transfer is always a critical time. And so you don't want anything hanging out or loose for someone to inadvertently grab it and pull it out, and then you don't know until it's too late.
So I know for ground medics, we teach them to reassess after every movement. Do you do
Yes.
the same thing?
Absolutely.
Okay.
So that's one of the main things, I don't care if you move this person 2 feet. Make sure you reassess, go through doing a good primary survey where you don't have to intervene. It takes 5-10 seconds, just to run through it, make sure I've got airway, breathing's good, circulation's still good, there's no massive bleeding anywhere. And then all my lines are good and in place in order. Nothing has been, you check your lines, look at it, make sure nothing's been pulled, make sure your vent tubing is still connected. I talk about vent tubing a lot because that's kind of what we do. But, if you're just bagging the patient or whatever, make sure that you're, connected correctly and everything's working right. So yes, that reassessment is when I fly personally and again in our environment, that's all I'm doing is just a constant head to toe. If I'm not doing something actively intervening, giving them medications, I'm right back to doing my head to toe ABCD.
So there's never a time when you're bored, you're trying to find something to do.
Nope.
Yeah.
Never. And even if I'm doing something like I'm trying to write something down and document, I'll even put my hand on top of the chest just so I can feel that rise and fall as I'm writing because, I'm very paranoid that I'm going to miss something. In the helicopter, you can't hear. So if my vent's alarming or my monitor's alarming, I'm not going to know that. I'm not going to hear it. So I have to not only look at the monitor, I don't like to always rely on just, my electronics, but looking at my patient and making sure that it corresponds with what I'm seeing on the monitor or, making sure that I didn't miss anything. So yeah. And then if you're, you lose your hearing, you might lose your vision as well because if you're in the dark, then it's very hard to see. So again, that feel is huge. So I'm constantly, feeling the expand of the lungs and the chest, and feeling for any fluids or liquids that they're bleeding out. It's big. I'm never bored. It's 100% on the whole time.
Before you actually get on the bird or the helicopter, do you do anything different as far as actually securing lines, securing the tubes differently or more securely?
I make sure that it's all within whatever I package the patient in. So if it's apples, it's all within the inside of it. Mm-hmm. If it's blankets, that when you put the straps on the litter, that it's all contained within. Because if it's outside of the straps or outside of the blankets or the apples, then it's going to just be hanging there. Someone's going to grab it for sure. And
okay.
So the security there's not anything like specific. I just make sure it's all contained within where it needs to be. We'll mark the lines too, so we can see. You might put like a piece of tape or something that signifies that this is my IV line or this is my ART line. Somehow. But, big Sharpie pen, whatever, just to identify the difference between the lines.
Now, I know you don't do the CCAT, the Stratovac, but are you using the SMED and, putting pumps and vents on there? Because a lot of us haven't seen the SMED before. I saw it in Cincinnati, but that thing is a huge erector set that kind of sits over the patient.
So when I was in Afghanistan, that's what we used. That was in our AMOL or our supply system is the SMED. I really liked it because it was very simple to connect to the Army litters that we use. It was specifically made for the monitors and the vent. Had a place to put your oxygen. Some people didn't like it because it was added weight, but I found that it kept it off the patient. It was all contained in one area. And the other nice thing about it is I could swivel the monitor. So if I ended up in a situation, like I said before, where I wasn't placed in the aircraft where I thought I would be, and if I may have positioned my monitor because I thought I was going to be on the right side, and then it turns out I'm on the left side, I could pull the little lever and then it swivels, 360 degrees to wherever I'm at. So I liked it, but they're not around anymore. So
yeah.
Or I think they're on the CCAT uses them, but maybe.
Yeah, I'm not sure. I know it does makes it a little easier when you have a bunch of different things to attach to it, the pumps and the drips and the vents. But.
Yeah, and it just keeps it off the patient. A lot of times I've seen guys putting the monitors, putting the Pleurovacs, putting everything directly on the patient, and then they go running off. Stuff is not secured down,
Right.
and not to mention you're just putting all this weight on somebody's chest who's already having a hard time breathing.
Yeah, it gets to be a little, you have to be very strategic where you put your monitors if you don't have something like the SMED. Sometimes you do have to put it on top of the patient. You try to avoid any injuries, obviously. One thing I learned is to take an extra blanket and fold it into a square for padding. And then if you have to put the monitor on top of the patient, then you put the little square blanket down and then you put the monitor on top, and that just creates a little extra room between that and the patient. And then, oxygen bottles between the legs, we do that a lot. However, that will pull the heat from the patient. So you have to make sure if you do that. I see it a lot in training, like people just throw the O2 bottle between the legs without thinking about that. So if you have the oxygen bottle between the legs, make sure you are wrapping that up in something, a blanket or whatever, so it's not going to pull the heat from, because O2 bottles are cold. So, you have to, it's really based on, what you have. If the person has an amputation, you have a little extra room to put your monitoring, your equipment there. But the biggest thing is placing your equipment in a way that makes sense if you have to do it that way. So if they're vented, making sure the vent is closer to the patient's head. The monitor can kind of be anywhere. Just you need to be able to see it. And then the suction, usually they'll put the suction on top too, but you have to think if I don't have room for something, then suction doesn't have to go on top because you're not actively using it all the time. So these are some of the things. It sounds, I don't know, maybe common sense, but when you get to that point, and I run scenarios with my guys all the time, that's the one sticking point is they don't know how to package the patient. And I get a lot of questions about how do you do this, especially if you have multiple monitors or equipment. So it's huge. It's a big thing. It's kind of like the handoff where nobody really talks about it, but it's one of the bigger things in patient care.
So when you run one of those scenarios, what does that kind of look like when you're running your nurses or corpsmen through one of those scenarios?
So we will do, we'll act like we're at the Roll 2 and they've just come out of damage control surgery or damage control resuscitation. So there'll be a doctor and a nurse that may not know really what's going on, because that's pretty common in those situations. Everyone's kind of running around and a lot of people don't know a lot about the patient. So we set it up in a way to where they get very limited information. So they really have to do that pre-flight assessment and be in depth, but we also put them on a time limit, because if an aircraft is there and waiting for you to take the patient, they're not going to sit there forever. So you got to be able to do a thorough primary assessment, secondary assessment, and plan what equipment you need to bring, medications, how much oxygen you need to bring within a certain time frame. And that's the biggest part for them. And then that transfer. So how do you transfer this patient? How do you carry them? We put them on a helicopter or whatever vehicle we can get for our training. Can't always get helicopters. So we'll do a 997 or whatever it is and throw them in there. Make sure that they do that reassessment once they get into their aircraft. And then take them through some scenarios while we're moving around. So we'll have something happen to the patient, whether it's, airway issue or, they lose blood and they have to catch that and then intervene appropriately. So,
So another super important point other than en route care is the actual handover.
Yes.
Either between the ground medic and the flight medic, or from the physicians to the flight medic for a transfer. How do you want this to occur?
So what I teach and what I've always used was the MIST report. So the mechanism of injury, the injury sustained, their signs and symptoms, and then the treatments and the interventions that you did. I found that to be the easiest and quickest and most thorough way to hand over a patient in what we do. And it covers everything. I always say that your care is only as good as your handoff. And by that, I mean, you could have done the most amazing care in the most stressful environment, but if you sound like you don't, your thoughts aren't organized, you're all over the place when you hand off that patient, you're automatically going to be judged. I mean, that's human nature. They're going to judge you based on your handoff of how well you took care of your patient, which isn't fair, but that's just the way it is. And on the flip side of that, you could have been a complete disaster taking care of your patient, but walked in and gave a, rockin' report, and everyone's like, oh, wow, they're great. So you really have to make sure that your handoff is organized and it covers everything that the receiving team needs to know. So, I mean, things can be detrimental to your patient if you don't report, what you've done. For instance, if you gave them a certain medication right before you hand it over, but you forgot to mention that, and they give them another or the same medication, now this person's getting double dosed, and that can be detrimental to your patient. So it's really important that you're able to do that and do it accurately. A great handoff, you'll have no questions. The receiving team will have no questions for you. So you know that you've done well in that, and that's what you need to strive for.
So if I'm doing a handoff to you, what do you want to hear from me?
So the biggest thing is I want to know what happened to the patient, so that mechanism of injury. What injuries did they sustain? So not only the injuries during the mechanism of injury, but the injuries also during your care. So the initial injury may have been an amputation of whatever extremity, but during your care, they also had a tension pneumothorax that you had to intervene on, or they lost their airway, whatever it is. So I consider those significant injuries as well. So I want to hear about that. Sometimes people will flip the S and the T. So when I talk about the injuries, they'll say the treatment and the interventions at the same time. So, the person had a below the knee amputation of the right extremity, and we put a tourniquet on, etc. So they put the injuries and the treatment together. You can do it that way as well. But I want to know the significant events. I don't need to know all of your vital signs. I want to know what their current vital sign is, and I want to know if there were any trends where they dropped, anything significant that you had to do an intervention on.
So if they're just trending up, they're trending upwards or trending downwards, stable, not stable, things like that.
Yes. So, I mean, if there was one point where, they were trending or 120 over 60 or somewhere in that ballpark the whole time, but then all of a sudden they went down and they became hypotensive, 70 over whatever. Okay, what happened there? Obviously that was a significant event. Well, we discovered we had a tension pneumothorax. We did a needle decompression, or we put a chest tube in, or whatever it is, and then that's what I want to know. The medications that you give in, how long ago did you give the dose? Time, how much fluids did you give? There's something else I was thinking of too.
Like tube depths? Yeah,
if they're vented, so that's important. I want to know the settings that you're using, where the tube is at the teeth. We always say measure the ET tube at the teeth versus some people say the lips, but the lips swell or they move, so that's not as accurate as if you say at the teeth. So that's a big thing, is a lot of people don't think about that. So, whoever intubates does their thing, and a lot, the nurse or the corpsman takes over. They don't think to ask where on the ET tube was the placement, because that's part of the DOPE algorithm, right? Is dislodgement. So I need to know if I'm having issues with my airway or my vented patient, did it get dislodged? Well, how do I know that if I didn't know what the initial measurement was to begin with? So it's really important, and I find that it's not really trained a lot or talked about a lot. And their level of consciousness, that's a big thing, especially if they're vented. I want to know what was their level of consciousness initially and during your care. If they lost that, GCS scores are great if you know it.
So I think as you're talking about the intubation, the tube, this is where we can kind of talk about that, filling the bulb with saline.
Yes. So we don't do that.
Yeah, it's one of those myths that it sounds like a sexy thing to do as you're going up in the air, and it's actually been proven to not be as effective. But there are some issues with that if you're going to do that.
Yes. So it was found with a study that you can actually cause damage to the trachea. If the balloon ruptures, you have the saline or the fluid, whatever fluid you put into it. So it's not recommended in most protocols and in most of the air bag protocols as well. Even in the civilian sector, they don't recommend doing that.
So what would you do then? Do you carry some kind of cuff manometer or cuffle or something like that?
Yeah, so that's a lot of times I know in the civilian sector they do carry that, and you're supposed to monitor that and record it. For us, we don't have that specific tool, but testing that balloon that's hanging out and making sure that's inflated, and just watching. If you have a low pressure alarm, you can assume that either it's deflating or high pressure. I mean, it shouldn't be a high pressure alarm if it's inflated appropriately. So it's really at that point is if it's deflating and you're losing.
So is that something you just add to your reassessments?
Yes.
Okay.
Yep. So when I do my head to toe, my A, B, C, D, E, in the breathing part of it, I'm looking at, I'll test that little balloon and make sure it's good to go. Look at my monitor, my settings, and tidal CO2 is what we monitor with if they're vented, but your SpO2 and that type of thing.
So I know we brought you in here to talk about the 10th prolonged field care capability in prep for flight, but really it's prep for evac. And so I know you've done a lot of rotary wing, but you've done a lot of ground as well, right?
So again, with the Marines and the Navy, we don't have a designated medevac unit or a designated aircraft. So when we talk in route care, a lot of times we think of the air, but it's really any vehicle that's available for you. It's just treating a patient in movement, going from one place to another, and that can be a helicopter, it could be a vehicle on the ground, a 997, an LCAG. I mean, it's anything to get them moving. So yeah, it's again that planning phase is huge, and the preparation phase is big because you just don't know what you're going to get. We call it lift of opportunity. So whatever is available and around, and we've been spoiled the last 16 years with having that air capability, and we call a 9 line in, and we're not waiting too long to get a bird over. But I think for future endeavors, we're looking at things that are larger AORs and a lot more time to either transport the patient or get to the patient. So we have to think in terms of, and if we don't have that air superiority, so it might not be the air, it might be a lot of different things that are just moving, and being able to plan for that.
Right.
And so when you're planning for a movement, you brought up earlier when we were talking before the podcast about nausea for the caregiver. So you want to elaborate on that here?
So and that's part of my training too, is that we will designate in the Navy a nurse as an en route care nurse with pretty limited experience in an ICU or an ER. And our ERs in the military hospitals aren't very high acuity, so you don't really get a lot of that critical care experience. They may or may not have gone to the JEC course, the Joint En route Care course in Fort Rucker, and suddenly they find themselves in a situation where they're the en route care nurse for their role too. But they may have never have gotten on a helicopter before that point. So what I want to do is, part of this training is getting them exposed to different aircraft, different helicopters, getting them on the up in the air or in a vehicle, taking care of that patient and seeing what it's like when you have that movement. You're not focused on, the horizon or whatever else, but you're focused on something else within the aircraft. That always, if someone's going to get nauseous or airsick, that's usually when it happens. So my big thing is that you have to know as a provider, how are you going to react physiologically in that aircraft or that vehicle or whatever it is before you have the actual patient. Because a lot of us found that the first time we're flying is with that critical patient, and I don't even know how to speak to the crew because I've never been on an aircraft. They didn't bring me a headset, so I'm doing hand signals and different kind of things. So yeah, it's that preparation phase. If you're in a unit and you know that this is a possible mission, is training your guys to be able to do this, getting them on those different aircrafts or vehicles, or looking ahead and looking at the environment we might possibly go into, and how would you deal with that, and
Right.
what are you going to use to move your patient, how are you going to do it and plan for it. So
Right. But I mean, even though we might use a variety of different vehicles, could be air, land, or sea, packaging your patients, the misreports, that type of planning and communication, that is going to be constant regardless, correct?
yes, yep, always have it in the back of your head, and like I said, always be 2 steps ahead. So I always train my guys, never look at your patient as being stable. Always look at them as what can go wrong, what are the worst case scenarios, and how do I plan for that? So when I have them doing that assessment, when you're looking at the airway, they may be intubated, everything's great, the placement's good, the vent settings are great, it's working for that patient. But you got to look at it and go, okay, what can go wrong at this point? Go down that dope algorithm in your head, and if it's dislodged, what do I have to do? What are my rescue airways? How am I going to deal with this? If it's obstructed, how do I deal with this? Oh, I need suction. I need to bring my inline suction catheter. A lot of people forget that. Pneumothorax. Oh, I need my needle Ds or chest tubes or whatever it is. So you got to think that way as you're doing your assessment. So you have to plan, because we have to bring everything we need on with us. So if I forget my needle decompression needles, or if I forget chest, whatever it is, however I'm going to fix that situation, and I find myself in that situation, you're in a helicopter or you're in a vehicle and you're not anywhere near anybody else. So, how are you to deal with that? People have forgotten the ambu bag. What's the first thing we do if we have an airway issue on a vent is we take them off the vent and we start bagging. Well, if you don't bring your bag and your vent's dying on you, which has had on, I've had a flight where as soon as I got on the aircraft, the vent died. So if I didn't have my ambu bag, that would have been a really bad day. But yes, it's all about that planning phase and being 2 steps ahead always. So.
Do you ever have issues where you don't have enough drugs, you don't have a reversal, or, something like that?
I've never had that issue, but you definitely can run into it. And that's why we always say you need a plan for, if your flight's a half hour, you need to plan for an hour and a half with your medications and your oxygen and that whole thing. Bring your reversals for your benzos and the narcotics, usually the opioids are what we're using. So bring those reversals that
Do you do anything with your patients as far as if you're in the air? We don't talk to very many flight medics. Most of us are ground guys, but and they have some kind of delirium and you're in the air, that could be a dangerous situation. Do you ever tie their hands down? Do you give them extra sedation? Anything like that?
I personally fly with my patients paralyzed.
Yeah.
Because again, with our aircraft, it's not set up for medevac. It could be set up for, defending ourselves, and so there's a 50 cal on there, and they're firing that 50 cal off. There's a lot of stimulus in our environments, and so to avoid that situation, I prefer them to be paralyzed and obviously appropriately sedated with that, because I'm already in an aircraft that's not set up for a medevac, and now I have a patient who's flailing, and my biggest fear if they're vented is they're going to pull that airway. So I in the back of a 60, I can't, the way the patient's usually positioned, I can't get behind the head. So if he pulls the airway, it's going to be, again, another bad day trying to handle that. So it's just a difficult, very stressful situation. And the reason why I came up with that training again, because it is a disservice to the provider and to that patient to throw people in these, expect to have them go into these environments and just know how to do their job because they were working in an IC or ER for a few months.
So is that course becoming more standardized now after you've been doing it for a few years? How long have you been doing it?
I started it 2 years ago, and I have a great team that's been helping me out, and it really was meant for my battalion and for the companies that are going downrange and deploying, but the word kind of got out to the other units, and so I had a lot of different units on the East Coast and also in Okinawa, and some of the wing units as well that are asking for the training. Again, it's not an official course.
Yeah.
It's just training, but we have created a mix of didactics and also scenarios and coordinating, aircraft and that type of thing into it. So these guys really get some kind of a experience and know what to expect. And I did it solely on my experiences. So it was easy for me to create it because I knew what I did wrong and what I wanted to know and the lessons learned. So that's how I sort of laid out the structure of the training that we do.
If somebody wanted to go to that training, how would they go about doing it?
So right now we've had a lot of, because the word kind of spread, I I have corpsmen from other Marine units that aren't even attached with the medical battalions or the air wings that are asking to come over and do it. And as long as they can get the time off to come over, then they're all welcome. So I'll travel to people and teach them. I have no problem with it. I'm a big person. I'm a big proponent on training and being prepared and not putting people in really bad situations like we've done a lot in the past. And so as long as people want to hear me talk, I'll keep talking.
Yeah.
How will they get in contact with you?
They can get in contact with me with either by email or phone number. I'm on my way out of the military, so
Okay.
Or they can get a hold of my team as well.
Okay.
And that's at 1st Medical Battalion.
Okay.
And that's
Camp
a
Pendleton.
Camp Pendleton on the West Coast. Okay.
Okay. We can put that contact in the show notes.
Yeah, we're also going to have to name drop the course that we're at right now, the SOF Austere Critical Care course. So we have her over here helping us out. This is, I don't know, second or third time you've been out here to help us to do exactly what we're talking about today, to kind of talk to our students who are non-medics going through this prolonged field care training about handovers, about in-flight issues, and everything else. So we'll put the info for the SOFAC course as well on there. So if anybody's interested, if you're a SOF non-medic, you can come to this a month-long course. We have an OML, of course, and if there's seats available, we can try to work you in.
Yes, I will. Just as another plug, just having been involved with this course, it's been amazing, and the fact that it's set up for non-medics. I mean, my corpsman, I have a corpsman here actually going through the training, and he said himself that he's learned more in the few days he's been here than he has in most of his training that we've offered for our Quad Zeros or 8404. It's a phenomenal course, and these guys walk away with so much medical knowledge that this alone would help out the majority of the 68 whiskeys or the Quad Zero corpsmen around. It's great to see it come together.
We appreciate it. I don't know if people notice this, but we're in a garage right now. We're going to put up some pictures. We're in one of our austere clinics. We have heaters blowing because it's 30 degrees outside. And this is what our students kind of operate in while we're here.
It's realistic.
Did you want to talk about the JTS or the Committee on En Route Casualty Care? That's where I actually met you in San Antonio. So,
yes, I mean so for the future for me, I'll be working on one of the process improvement teams with the JTS. Part of the co-work. We've had a lot of, in the past couple of years, I think, a lot of committees stand up on en route care and recognize the importance of it and the problems that could potentially happen if we do, end up in a larger scale conflict. So the CORC has been trying to develop CPGs for the en route care environments, and JTS is it's a system that's always trying to improve trauma within the military. So I'm looking forward to continue working with different groups.
Yeah, I think it's important that we talked about that because in the prolonged field care, that 10th core capability, prep for flight, prep for evac, we haven't really touched on it much at all. One of the reasons why is because there's a whole other committee that's, focused on en route care. So that's prepping your patient, that's in-flight care, that's stratovac off the continent, that's care on ships. So it would just be ridiculous for us to try to recreate that when you have a whole committee focused on that effort.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.